Good morning. Hi. Welcome back. And I don't know, there's probably a few of you who weren't here yesterday, so greetings to those of you who were not here yesterday. Yesterday was a really terrific day, I think. We had about over 180 people or so here yesterday, and this was really terrific. Today are just a couple of announcements before I introduce our speaker today. Our sessions today are a little bit more spread out. I think we're up on the 6th floor some. You can take an elevator right out here, right to the left of the bathrooms is where the elevator is, and you can take it up to the 6th floor, or you can walk up the stairs that are right here as well. We are already on the 4th floor, so it's only 2 floors above us. Today's lunch will be a box lunch, and I think they'll be right out here again, and so make sure you get there. That's at, Tina, that's at noon, the lunch? Okay. Okay, and I also have something here, a quick reminder to be sure to take a few moments to help us fill out that conversation bubble. I haven't looked at it today at all, but there were a few yesterday. And now I'd like to introduce somebody who probably needs no introduction, except for that some of you may not know who he is. So. It is really my great pleasure to introduce Martin Philbert. He is a professor of toxicology, but most importantly, he's my dean of the School of Public Health, so I have to be especially nice in this introduction. He earned his doctorate at, and I have my little notes here, because I didn't know this, some of these facts I didn't know about. But he earned his doctorate from the London University Royal Postgraduate University, postgraduate medical school, and he was awarded a postdoctoral fellowship from Rutgers University in my home state. Does anybody know where that is? The Garden State of America. He's been at the University of Michigan since 1995. He started as an associate professor, serving on several key roles, including our associate dean for research. And in 2010, he became the dean of the School of Public Health. He chairs a number of national science committees and has served on the National Advisory Environmental Committee, the National and at the Institute at the Environmental Health Sciences for the National Institute of Environmental Health Sciences. In 2012, he was elected to membership of the Institute of Medicine and the National Academy of Sciences, and in 2013, he became a fellow of the Royal Society of Chemistry. But really, more importantly, he's been a really great supporter of the Injury Center and injury research and prevention at the School of Public Health and at the university. And so I am honored and delighted to introduce Dr. Martin Philbert.
I'm always nervous when Marc says he's going to be kind. Thank you for that kind introduction. Good morning and welcome to the second day of preventing injury from research to practice to people. The School of Public Health is an enthusiastic partner in the University of Michigan Injury Center, which is joined with the Michigan Injury Prevention Alliance and the Minnesota Department of Health to sponsor this unique conference. This event brings together practitioners on the front lines of injury prevention with researchers who are advancing the frontiers of injury science. The translation of research to practice is often a missing link in public health. This meeting presents wonderful opportunities to forge new partnerships and to move recent advances in injury research to practice settings. This event is particularly timely for the School of Public Health as we prepare to launch a new graduate certificate program in injury science beginning in January of 2014. Successful approaches to decrease the burden of injury require innovation from well-trained public health workforces. This certificate program is designed to actively engage students in coursework and internships to increase their knowledge and competencies in critical injury content areas, to incorporate multiple disciplines and theoretical perspectives from coursework from across campus, and expose students to the latest methodologies to address injury prevention needs of vulnerable populations. The certificate program will be open to all master's degree, PhD, and medical students at the University of Michigan who have successfully completed at least one semester of coursework. The certificate represents an important addition to the school's academic offerings and recognition of the centrality of injury prevention in public health. I'm particularly pleased to have the opportunity to introduce today's keynote speaker, Dr. Grant Baldwin, an alum of our School of Public Health. Grant received his PhD in health behavior and health education at the University of Michigan School of Public Health in 2003. He also received an MPH in behavioral sciences and health education from the Rawlings School of Public Health at Emory University, whose dean is also an alum of the University of Michigan. He is the director of the Division of Unintentional Injury Prevention at the National Center for Injury Prevention and Control. The Division of Unintentional Injury Prevention is dedicated to reducing the number and severity of unintentional injuries through science-based programs and applied research. CDC is focused on preventing injuries and fatalities, including those related to motor vehicle crashes, prescription drug overdoses, older adult falls, and traumatic brain injuries. Today, Dr. Baldwin is going to speak to you about the National Action Plan for Child Injury Prevention, which he was instrumental in developing. Welcome back to Michigan, Grant. We're delighted to have you here today.
Well, good morning. Thank you for that warm introduction. It's certainly great to be back in Ann Arbor. By every measure, injuries exact a staggering toll on Americans, leaving lives lost or shattered by tragedy. But by every measure, there are many things we can do to prevent them and make our lives safer. I'll be talking about opportunities for injury prevention across the lifespan, discussing pressing injury issues here in the United States, and asking how and why we can be doing more. I'll crosswalk injury issues as we age with the power of prevention, viewed through a social, ecological, and life course perspective. By the end of my remarks, my hope is that you both understand these issues and maybe have some ideas to inform your work at home. So this is Michigan Stadium on a typical football Saturday, and like every great football program in the Big Ten, going to a game here is filled with tradition. Tradition not easily captured on TV. Whether watching players and coaches run onto the field and touch the Go Blue banner, or the marching band play a Hail to the Victors for the first time, the atmosphere is electric. Another one of the traditions that I really enjoy is the introduction of the opposing team's players. The Michigan football players are introduced with great cheer, and this is where it actually gets interesting. When the public address announcer introduces the opposing team, he pauses after each player's name, and in that moment, 110,000 people yell, "Who cares?" The pattern repeats, player introduction and who cares for everyone on the roster. A few years ago, I read Start With Why by Simon Sinek. The book is about how to make big things happen when those you serve or are trying to influence understand your core motivations, your whys. These whys drive everything you do. They define you. While I'm not sure any action could influence a Michigan crowd to care during the introductions of the opposing team, I think there are at least 3 whys we can use to inspire action in injury prevention. They are the numbers, the burden of injuries, a belief, the human right for everyone to live safe and injury-free, and a storied opportunity, the opportunity to save a life with the widespread adoption of a known effective intervention, and the tragedy of the loss when this doesn't happen. There's a 4th why that I think is uniquely our own in public health. It is the unspoken core tenet, science in action to protect and promote health for the greatest good for the greatest number of people. People rally behind whys because it gives a meaning and grander purpose for action. It is the intersection of these whys in injury prevention that make our calling so compelling. By now, this four-stage public health model is probably familiar to most of you. At CDC, we use it to guide our work. In this model, we move from traditional surveillance to risk and protective factor identification, to the development and implementation of programs and policies. Finally, we aim to bring proven evidence-based interventions to scale. We view solutions to the public health challenges we face as rooted in the social ecology. In other words, the factors depicted on this slide interact with one another to create or reinforce health. It is not just about individual choice or genetic predisposition. Social relationships matter, neighborhood and community conditions matter, local, state, and federal policies matter. And all of this plays out over our life course. I'll be narrowing in on the important role of policy in prevention and how time, place, and life circumstances interact to influence outcomes. CDC Director Dr. Tom Frieden is particularly energized about the role of policy, or changing the context of public health decisions and making healthy and safe choices easier. In general, public actions and interventions represented by the base of the pyramid require less individual effort and have the greatest opportunity for a population impact. Interventions at the top tiers are designed to help individuals rather than entire populations, but could theoretically have a large population impact if universally and effectively applied. Here, there are challenges with scalability. In the area of violence prevention, the Adverse Childhood Experiences Study has shown that early childhood trauma, like physical, emotional, or sexual abuse, can have deleterious impacts for the victim throughout their lives. And the more trauma they experience, the worse the outcomes. Survivors of early childhood abuse are more likely to have risky healthy behaviors like abusing drugs or alcohol, smoking cigarettes, maintaining a poor diet, and being sexually promiscuous. They are at a greater risk for a range of long-term chronic conditions like cancer, heart disease, and others. The principles of life course theory are relevant to unintentional injury prevention too. I'll describe 4 of them during my remarks. As this girl ages in the picture on the right, her life trajectory, transitions, and turning points could be interrupted or greatly influenced if she is severely injured. So let me get back to the whys. The first why is the numbers. As infectious diseases have come under control in the last century, the relative importance of injury as a cause of mortality has increased to the point where it's the leading cause of death for people ages 1 to 44. Regardless of sex, race, or economic status, injuries affect everyone and can result in short or long-term disability. The burden of injury surpasses all major disease groups as a cause of years of potential productive life lost before the age of 75 because it's the preeminent cause of death among children and young adults. Each year in the United States, there are 180,000 deaths from injury, 1 person every 3 minutes. There are 29 million people treated in an ED for an injury and 2.8 million people who are hospitalized. In addition to the tragic human toll, injuries exact a staggering financial cost too. Injuries cost an estimated $406 billion annually in medical cost and lost productivity. In an era where cost-saving interventions are more important than ever, a decrease in injuries can afford substantial cost savings. If you are between the ages of 1 and 44 in the United States, you have a greater chance of dying from an injury than from any other cause. Not from cancer, not from HIV, and not from the flu. Injuries. This is driven largely by motor vehicle-related injuries and the growing epidemic of prescription drug overdoses. This chart also shows that the other leading causes of death for different age groups for both sexes include homicide and suicide. By the way, unintentional injuries are the 5th leading cause of death overall. So what about the proportion of deaths within the ages of 1 to 44 compared to others? In the United States, injuries, including all causes of unintentional and violence-related injuries combined, accounted for 51% of deaths among persons in that age group. Between the ages of 1 to 30, injuries and violence account for almost 80% of deaths. And later I'll outline for you some of the leading cause of injuries focusing in on topics that are current priorities for the Injury Center. I won't be talking about prescription drugs because I spoke about CDC's work in the area previously. Injury prevention at CDC gained new focus and attention when Dr. Frieden became its director in June of 2009. He set out to identify areas in public health where we can make a large and immediate impact. He calls these winnable battles. These public health challenges are not easy, or they would not be battles, and yet they are not hopeless because they are winnable. A winnable battle needs to meet 3 criteria. It must be a leading cause of illness, injury, disability, and death. Evidence-based, scalable interventions must already exist and are able to be broadly implemented now. And we have the ability to achieve dramatic results within 1 to 4 years. Dr. Frieden declared these 6 topics winnable battles, including motor vehicle injury prevention. And prescription drug overdose prevention is also a top priority for the CDC. The second why is the core belief that it should be a human right for everyone to live safe and injury-free. Most everyone shares the value that everyone should be able to thrive with the hope of living life to its fullest potential. To realize this vision, we must be given the freedom and opportunity to grow up safe and injury-free. We have an obligation to future generations to assure that this human right is met. Clean air, clean water, safe food are all taken for granted in the United States, but at one time they were pernicious problems for public health. Injury prevention is a new frontier for public health, and countries like Sweden, with their Vision Zero, are setting this benchmark. The third why is about the life-saving potential of our injury interventions and the tragedy of missed opportunities. As public health researchers and practitioners, we often focus on population-level change with good reason. But that said, in the everyday, I think one of our biggest whys is the opportunity to save a life. Beyond the numbers, these are real families and real people. 2 weeks ago, I was reminded of the power of the story when a colleague and friend in Columbus, Gary Smith, told me the story of their efforts to get a bike helmet law passed in Ohio. Even the staunchest of elected officials can be moved by a story. You and I already recognize this promise and opportunity, and I think we can use it to inspire others. The final why is the core tenet of public health. It is science in action to protect and promote health for the greatest good for the greatest number of people, and that's what we are all about at CDC. While CDC has been doing work in injury prevention since the late 1970s, the National Center for Injury Prevention and Control was founded in only 1992. We recently celebrated our 20th anniversary. Today, we see this greatest good being realized with greater emphasis on injury prevention. I want to shift my talk and focus in on child injury prevention. Let me start with a story. This is 3-year-old Kayla Armstrong. She drowned in her family's pool on March 7th of this year in Van Buren County, Tennessee, near Nashville. When she was found, CPR was performed and Kayla was taken to White County Hospital, where staff were able to regain a pulse and labored breathing. She was then taken to Erlanger Medical Center in Chattanooga, and she died the next day. Her mother, 22-year-old Samantha Breimer Armstrong, was charged this past Friday, September 27th, with 1 count of child abuse and 1 count of neglect. Breimer Armstrong told investigators that she had left Kayla unattended. She played video games in the back bedroom with a pair of headphones on for over an hour. This is one face of child drowning in the United States. My commitment to child injury prevention is long-standing. However, like most parents in this room, this passion took on new meaning in July of 2011 when I became a father. When my son Aaron was born, I made a silent promise myself to do everything in my power to protect him from harm every day of his life. The people and organizations in this room have worked for decades to make this promise easier to fulfill. To be sure, the field of child injury prevention has seen significant successes, but much work remains to be done to truly fulfill our promise of protecting our children. On April 16, 2012, CDC and partners launched the National Action Plan in conjunction with the Morbidity and Mortality Weekly Report and Vital Signs, releasing new data on trends over the last 10 years on child injury deaths in the United States. Vital Signs is a monthly series introduced by CDC Director to focus attention on a key public health issue. It showcases a headline public health issue needing pressing action. By every measure, this is a problem. Between 2000 and 2009, the annual rate of child injury deaths fell by almost 30%. However, child injuries remain the leading killer of U.S. children, with over 9,000 children dying in 2009 alone. That represents about 1 in every 5 childhood deaths, or about 1 child injury death every hour of every day of the year. While the majority of injury topics saw significant declines in the 10-year period, led by declines in motor vehicle and fire and burn deaths, death rates from some injury types, including suffocation and poisoning, are on the rise. There was a 54% increase in reported suffocation among infants less than 1 year old, and a 91% increase in poisoning rates among teens 15 to 19, driven largely by the prescription drug overdose epidemic. As usual, fatalities are just the tip of the iceberg. For every child that dies in the United States, 25 are hospitalized, about 925 are treated in an ER, and countless others are treated in doctors' offices. Every year, about 1 in 10 children in the U.S., 1 in 10, are injured severely enough to seek treatment in an emergency department. To set a benchmark for what is possible, it's helpful to place the United States into the context of other developed countries. Unfortunately, the U.S. has fared relatively poorly in preventing child injury. This figure shows the unintentional injury death rates among children 14 and younger in selected countries in 2008. The U.S. highlighted here with the purple bar. The United States has 4 times the rate of child injury deaths as leading countries like Sweden, Netherlands, and the United Kingdom. State trends are equally sobering. This map shows the 2009 injury death rates by state. States with the lowest death rates, below the national rate of 11, are in pale yellow. States with death rates between 11 and 18 are in orange, and states with rates 18 and above are in dark red. Rates varied widely, ranging from fewer than 5 deaths per 100,000 children in Massachusetts and New Jersey to more than 23 per 100,000 children in South Dakota and Mississippi. In that year, more than 5,700 children's lives would have been saved if the lowest state death rate had been achieved nationally. The CDC focus on child injury prevention has evolved over time, but one catalyst for our increased involvement was the launch of the World Report on Child Injury Prevention by WHO and UNICEF in December 2008. The report called attention to the scope of the problem and reinforced that any gains in child survival attained through immunization, nutrition, and maternal and child health in the first 4 years of life can only be sustained if injury is also addressed. We used the launch of the World Report to refocus attention on the problem here in the United States, including launching a health communication campaign called Protect the Ones You Love. In this successful campaign, we placed special emphasis on the role of parents and caregivers. We saw our role as identifying and sharing tools and strategies to prevent child injuries and support organizations and individuals in their implementation. But we were called upon and challenged by then Injury Center Director and, frankly, by ourselves to do more. CDC worked with 60-plus national experts and partners in child health, emergency medical care, child advocacy, epidemiology, injury research, etc., to draft the NAP over 2.5 years. It was truly a collaborative plan laying out the future of child injury prevention and represents the best thinking by the best minds in the field. We worried and labored to get it right. Ultimately, the NAP seeks to create a vision for child injury into the 21st century and serve as a unifying call to action for partners with a stake in the health of our nation's children. The development of the NAP reflects its vision of a coordinated, multi-sector approach to child injury prevention, and the picture on the left is its cover. Overall, the NAP had 3 big and ambitious goals: to raise awareness about the problem of child injury and the effects on our nation, to highlight prevention solutions by uniting stakeholders around a common set of goals and objectives, and to mobilize action on a national, coordinated effort to reduce child injury. The NAP provides a framework for guiding national, state, and local efforts to reduce childhood injuries. It offers, really for the first time, a set of specific goals and actions that can be used by federal and state agencies, advocates, NGOs, and policymakers. The NAP is built around 6 domains listed here: data and surveillance, research, communication, education and training, health systems and healthcare, and policy. Each domain contains goals and actions based on what we know, where we need to go, and how we can get there at the broadest level, and it can inform actions by injury topic 2. Now we are focusing on moving from planning to action. We are funding a few small-scale seed projects, including with some of you, to coalesce and advance the field in 4 ways. First, strengthening collaboration among key stakeholders, including on programmatic and policy priorities to ensure one-voice messaging. Second, providing tools for the field to improve data and consistency in program execution. Data helps us assess progress and identify gaps. Third, showcasing the promise of evidence-based programs on high-burden topics, like motor vehicle injury prevention. And finally, building capacity in hospital settings and among employer networks. The focus is on prevention, before or after an injury occurs. In life course theory, the principle of linked lives suggests that social relationships matter, including family, friends, neighbors, and work colleagues. Life experienced by one person ripples throughout a network. A catastrophic event like a severe injury to a child greatly impacts the lives of everyone associated with that child. In an instant, the life trajectory of a child is altered, and the life opportunities for everyone closely linked to that child are altered too. So now I want to talk a little bit about teen driving, but by way of introduction, let me speak broadly about motor vehicle injury prevention first. I also want to talk a little bit about the importance of partnerships. Motor vehicle crashes present an enormous public health problem. More than 5 million crashes happen each year in the United States. In 2009, motor vehicle crashes killed more than 33,000 people in the U.S., more than 90 men, women, and children each day. They're the leading cause of death overall for persons aged 5 to 34. In the graph, note the stair-step decline in motor vehicle crash deaths by both raw numbers and by vehicle miles traveled. These achievements track to policy enhancements such as primary enforcement seatbelt laws. But for the first time in several years, early data from 2012 suggests that motor vehicle fatalities are on the rise again as our economy improves. There is almost a 7-fold variation in the age-adjusted motor vehicle death rate by state. Much of motor vehicle safety policy in the United States, as you know, is determined at the state level. States with stronger laws tend to have the lower death rates, but the relationship is not perfect. In 2006 to 2008, in the 5 states with the highest fatality rates, Mississippi, Wyoming, Montana, Alabama, and Arkansas, 79% of fatalities occurred in rural areas. For the 4 states, Massachusetts, Rhode Island, New York, New Jersey, and the District of Columbia, with the lowest fatality rates, 17% of deaths occurred in rural areas. Rural states have higher rates, even if they have stronger laws. Here are some of the key risk factors associated with motor vehicle fatalities in the United States. Specifically, in 2007, over 50% of all persons killed in a motor vehicle crash were not wearing their restraint. Over 30% of all traffic-related fatality deaths involved alcohol, and over 30% of persons were speeding at the time of the crash. Not surprisingly, these risk factors interact with one another, and the explanation for many motor vehicle-related fatalities is multi-causal. In 2007, approximately 7% of all motor vehicle-related fatalities involved all 3 factors. So what is our vision for motor vehicle injury prevention? Simply put, our role is to research what works and to partner to promote proven programs and policies that prevent car crashes and protect people from injury and death. Through public health leadership, we aim to keep people safe on the road, drivers, passengers, and pedestrians, every day. Our overall strategy is to promote motor vehicle safety through a multifaceted program of applied research, implementation, evaluation, and translation of effective interventions. As you will soon hear, our work complements the work of the National Highway Traffic Safety Administration, or NHTSA, and other federal partners in the transportation safety community. The areas presenting the biggest threats to motor vehicle safety are as familiar as they are persistent, and CDC's injury prevention efforts focus on them: seatbelts and child passenger safety, teen drivers, and alcohol-impaired driving. In 2009, about 12,000 more injuries would have been prevented and 450 more lives saved if all states had primary enforcement seatbelt laws. Seatbelts have saved 250,000 people since 1975. If a crash occurs, wearing a seatbelt is the single most effective prevention measure that you can take. Per mile driven, teen drivers ages 16 to 19 are 4 times more likely than older drivers to crash. We know that 2 things are proven to protect teens on the roads: strong GDL policies and involved parents and caregivers. Work done here at the U of M by Gene Shope and Ray Bingham and others is helping to inform these promising interventions. Finally, in 2009, almost 11,000 people were killed in crashes involved impaired driving. This is nearly 1/3 of all crash traffic deaths. Reducing alcohol-impaired driving, particularly recidivist impaired driving, is the subject of intense work at CDC. Each of these issues provides fertile ground for collaboration between NHTSA and CDC. This is 16-year-old Tyreek Hemphill. He was killed late Friday afternoon, September 20th, less than 2 weeks ago, in a 2-car accident on Highway 55 south of Riddle Road in Durham, North Carolina. The crash happened shortly after 4:30 p.m. when a northbound Honda driven by Tyreek crossed the median and drove into the path of a southbound Oldsmobile driven by a 36-year-old woman named Patrick Bailey. Police said Bailey tried to avoid the crash but was unable to. Both vehicles went down an embankment, and Hemphill was trapped inside his vehicle and had to be extracted by firefighters. He was taken to the hospital, where he was pronounced dead a short time later. Hemphill was a student at Jordan High School in Durham, shown here on this slide. Bailey was taken to the hospital for non-life-threatening injuries. The crash remains under investigation, but speed and alcohol do not appear to be factors. Tyreek was the epitome of a dreamer. He was raised with manners, morals, and goals, said grief counselor Tiffany Robinson. His drive from being someone and making something of himself inspired not only his peers, but adults who knew him, she added. He was an honor student thinking about a career in engineering, and the teen had hopes of leaving Durham and going to Howard University. In 2009, 8 teens, ages 16 to 19, died every day. Research shows that comprehensive GDL laws prevent teen crashes and save lives. Comprehensive GDLs are associated with reductions of 38% and 40% in fatal and injury deaths, respectively, among teen drivers. We also know that parents play a critical piece of the puzzle in setting and enforcing rules for their teens and leading by good example. We have a campaign called Parents Are the Key that provides parents with the tools and resources they need to stay involved in their teens' driving. We are working with several national partners to conduct a teen driving safety campaign, and the goal of the campaign is to increase awareness among parents of both teens' crash risks and the things that parents can do to keep their teens safe. Research suggests that by increasing parents' awareness of the need to manage their teens' driving and teaching them how to reduce high-risk activities, parents will more closely monitor and manage their children, leading to a decrease in motor vehicle crashes that involve teen drivers. I really like this I Pledge video that I'm about to show you. This is a very powerful why.
I pledge to make sure you always buckle your seatbelt.
Because you're safer with it on.
I pledge to limit your nighttime driving.
Because more daytime practice
will help you get ready for the challenge of driving at night.
I pledge to restrict the number of passengers in your car.
To protect you and your friends.
I pledge to practice driving with you and coach you to be a better driver.
I pledge to help you learn and follow our state's driving laws.
Because 16 years ago, I pledged to keep you safe when you were born.
By my hugs, I pledged it.
By my kisses, I pledged it.
During long nights, when you were sick, I pledged it.
With every scraped knee, every heartache,
and some tears, I pledged it.
I pledge to set a good example of safe driving.
Starting today, I declare the driver's seat
a no cell phone zone.
You can help me do this.
We can work on safe driving together. We can talk about it.
We can make an agreement.
I will make this happen.
I will make this happen.
I pledge this.
I pledge this.
I pledge this.
I pledge this.
I love you, so I pledge this.
I have to say, since I became a parent, I even get more emotional when I see that video. Partnership is an essential for our success in public health. NHTSA provides tremendous leadership in the area. Together, we are key players in the federal government's efforts to protect lives of Americans on our roads. Each brings different strengths to the field. CDC complements the work of NHTSA and vice versa. NHTSA is a regulatory agency working to ensure highway traffic safety. They advance a broad range of injury prevention policies, programs, and practices, establish and enforce safety standards, oversee critical highway safety grants and programs, and develop invaluable data-driven and authoritative behavioral and safety research. For our part, CDC is the nation's public health agency. We have strong formal relationships with state and local public health. We translate data into evidence-based programs and policies. In many domains, CDC functions as an impartial convener, bringing together partners from many sectors, and this is true in transportation safety too. Finally, because of CDC's global mandate, we are also taking leadership in the area of global road safety. CDC and NHTSA are working together to explore opportunities to work collaboratively with other federal, state, and local partners as well, NGOs like MAD, AAA, and Safe Kids. This is especially important in new and emerging areas like drugged driving, distracted driving, and risks associated with older drivers. Together, the two agencies bring people to the table and leverage differences in our appropriations, authorizing statutes, and cultures for a bigger impact. Another life course principle is human agency. The idea here is that we are not passive recipients of a predetermined life course, but make decisions that determine the shape of our lives. We steer a course. In motor vehicle injury prevention, there are individual choices like wearing a seatbelt, not speeding, and choosing not to drink and drive. But there are also policies that govern those individual choices like primary enforcement seatbelt laws, speed limits, and the provision of sobriety checkpoints, or the provision of ignition interlocks for the first-time DUI offenders. We are actors in a play that we write. The third topic I want to discuss is TBI prevention. Increasingly, we have a greater awareness of TBI in sports and the important role of keeping athletes out of competition until they have healed, even from a mild traumatic brain injury. Athletes who have ever had a concussion are at an increased risk for another concussion. At one time, the phrase TBI was foreign to the American public, but thanks to some high-profile cases in professional and collegiate sports and a commitment from leagues like the NFL, brain injury is more at the forefront of America's consciousness. By every measure, the data back up our need to be sensitive to the issue. USEDs treat an estimated 173,000 sports and recreation-related TBIs annually among children and adolescents between birth and 19 years old, 25,000 of those being in football. More broadly, there are an average 2.4 million ED visits, hospitalizations, or deaths in the United States related to a TBI, either alone or in combination with other injuries, across all causes of TBI in 2009. This graph shows the cause of TBI by age. Note that falls are the leading cause of TBI in the young and old, and motor vehicle crashes are the leading cause for middle-aged adults. We know a lot more now than we ever did about the implication of a head injury. And parents and coaches, trainers, and athletes themselves are being more and more cautious after a major hit. That said, CDC's Heads Up campaign, highlighted here, is helping to raise cultural awareness of the signs and symptoms of concussions and what to do about it for a variety of audiences. Greater awareness is an important first step. Football helmets have evolved immensely since they were first introduced to the game, providing greater protection than ever. It's not just about better head protection, it's about how we play the game. There's a lot more to learn and do. And recent news about former NFL players like Junior Seau and Paul Oliver, their suicides being partially attributed to their chronic traumatic encephalopathy, a degenerative disease caused by the multiple hits to the head they endured over their long careers, reinforce this point. Our heightened awareness as parents of even our youngest athletes in Pee-wee leagues and actions taken by legislators across the country passing tougher and tougher laws showcase America's growing concern for concussion. This is Zach Lysted. He suffered a debilitating brain injury as a 13-year-old in 2006 because his concussion wasn't properly detected or treated. He underwent 2 emergency surgeries after collapsing during a middle school game. Since then, he has spent every day struggling to recover and relearn basic skills. Recounting his story to the Seattle Times, Zach-Dad Victor said he was on life support for 7 days, he couldn't speak for 9 months. After 13 months, he could move his left arm a little. It took 2 years to get rid of the feeding tube and 4 years before he could move his right leg purposefully. In May 2009, the state of Washington passed the Zachary Lystat Law to address concussion management in youth athletics. The Washington law was the first state law to require removal and clearance for return to play among young athletes. Inspired by Zach's story, 42 states and the District of Columbia have passed similar laws between 2009 and 2012. In order to assess the implementation of return-to-play laws, CDC conducted a case study evaluation of return-to-play implementation in 2 states, Washington and Massachusetts. That report is shown here on the right. A third principle in life course theory is time and place. Our lives are shaped by when and where we are in the socio-historical perspective. Culture intersects with health. We have seen a dramatic shift in cultural attitudes about smoking over many years, marked recently by increased bans on where smokers can ignite a cigarette. Once glamorized, smoking is no longer a social norm. As our awareness about concussion matures and the social acceptance of putting anyone at risk for a head injury changes, I wonder what games we will play and how we will play them. The final example I want to highlight is at the other end of the lifespan. Specifically, I want to discuss older adult fall prevention. By every measure, over 1/3 of all older adults 65 and older fall each year. Those who fall are 2 to 3 times more likely to fall again. Every 15 seconds, an older adult goes to an ED because of a fall. That amounts to about 2.2 million older adults treated in emergency departments every year. Tragically, falls were responsible for more than 19,000 deaths in 2008. Hospitalizations are on the rise too. 1 in 5 falls causes serious injury. Between 2001 and 2008, the rate of hospital admissions for older adult fall injuries in the U.S. increased by 31%, placing an increased demand on our health infrastructure. Moreover, the direct medical cost of older adult falls is approximately $28.2 billion. Stated simply, the physical, emotional, and financial burden of falls on older adults, their caregivers, and families is really immense. Falls and the injuries they cause can affect older adults' independence, reduce their mobility, and compromise their ability to live in their own homes. Fortunately, we know that falls can be prevented. One important step we've made toward prevention is identifying the cause of falls and the factors that put people at greater risk. Fall risk is affected by biological, behavioral, and environmental factors. This includes biological factors such as age, muscle weakness, poor balance, and some chronic conditions. Behavioral factors such as taking multiple medications, inactivity, and risky behaviors like climbing ladders. And finally, there are some environmental factors such as lack of handrails on stairs or bathroom grab bars, poor lighting, and tripping hazards in the home. Recently, CDC Director Tom Frieden sent an email to all CDC leadership. In it, he wrote passionately about strengthening the linkage between public health and clinical medicine. Specifically, he called for improving prevention in healthcare. He laid out 5 key drivers where we could make a difference, including reducing practice variability, engaging the entire healthcare team, building accountability through health IT support, remaining patient-centered, and supporting innovation and evaluation. Fortunately, CDC's work in older adult falls prevention aims to do all 5 of these. To address older adult falls, we know that the most effective approach is clinical assessment by a physician or healthcare provider to identify and address a person's specific risk factors, and then referral to a community-based program. This can be very extensive. It may include taking a history of falls, assessing gait and balance, reviewing medications, evaluating neurological and cardiovascular function, and checking blood blood pressure, reflexes, and visual acuity. And at the community level, the CDC Injury Center is promoting those evidence-based fall prevention programs. To enable the widespread adoption of evidence-based programs, the CDC published a compendium of effective fall interventions. And the second edition was released last year. There's also a companion document for showing organizations how to actually do the work. For our part, we're now disseminating and implementing several of these interventions, including Stepping On, a physical activity and education program designed to improve strength and balance. It also includes education on home environmental safety and the importance of vision checks and medication management. Tai Chi for Moving for Better Balance is a 12-plus week program delivered by trained instructors and proven to improve balance using Tai Chi. And the Otago Fall Prevention Program, a program delivered in the home by a physical therapist using individualized exercise to improve strength, balance, stability, and range of motion. We're also very concerned about making sure that the work we do saves money. The CDC has worked hard to establish the return on investment for each of these programs to help them make the case that investing in fall prevention makes financial sense too, including telling this story to private insurers and managed care organizations. Each program CDC is supporting provides an ROI, with Moving for Better Balance and Stepping On being especially cost-effective. CDC, under the leadership of Judy Stevens, recently finished developing STEADY, or Stopping Elderly Accidents, Deaths, and Injuries. The STEADY Toolkit is a comprehensive and easy-to-use resource designed to help healthcare providers incorporate falls risk assessment and proven interventions into their clinical practices. The toolkit is very practical and includes a chart to help different types of providers incorporate fall prevention, suggestions about how to talk with patients about falls, assessment tools for several gait and balance tests, and a number of patient education materials. Here's a validated 12-item self-assessment tool called Stay Independent, adapted from work done by Larry Rubenstein at UCLA. Here is a stage theory-based tips for providers to talk to patients about fall prevention, depending upon their level of readiness to act. And finally, here are some gait and balance assessment tools, like the one-page primer on performing the timed Get Up and Go test shown here on the right. It may be a surprise to some of you to know that CDC's older adult fall prevention materials are among the most downloaded items that CDC has across any topic that CDC covers. The final life course principle I want to call out is timing. This refers to chronological ordering of events, not time in a historical sense. While we were working to prevent falls altogether, if an older adult falls, the timing of the event and its severity matter. So an active older adult falling in their early 60s is very different than a sedentary 80-year-old falling, both on the chances of a full recovery and on the risk of a subsequent fall. The point of all my remarks about life course is that injuries can instantaneously change your prospects, and who is there for you and what choices you make and we make as a society, including the cultural context, all matter. And the timing of an injury makes a difference in our health and well-being too. Let me close by adapting a quote by Khalil Gibran. He said, "We are the bows from which future generations as living arrows are sent forth." By the way, this is a more recent picture of my son Aaron at a park in Bethany Beach, Delaware in early September. As you might have guessed, I was responsible for dressing him that morning. I was recounting this story to Jean before I walked in here. Last weekend, my wife spelled out his name for him, and she asked him, "What does that spell?" Without missing a beat, Aaron said, "Michigan." I am regularly reminded with awe and some trepidation about the vigilance and importance of our work in injury prevention. The joy and promise in Aaron's eyes and in the hearts and minds of all children are too important. Aaron is my biggest why, and the only measure I need to keep doing what we do. Thank you very much.
questions for Grant? Anybody?
John Raisler from the Minnesota Department of Health. So one of my favorite things I kind of run with sometimes, I saw this MMWR report, and I included in some of my presentations, and it shows the 5 leading causes of death. And it shows the general trends over the last recent years. Heart disease is declining. Cancer is declining. Stroke is declining. CLRD is declining. Injury, unintentional injury, is increasing. Now, one of the things that I've been struck with, for example, in Minnesota, which is a fairly healthy state, fall mortality is about twice that of the national fall mortality. And I'm wondering if we're undergoing a new epi-transition. You know, the first epi-transition, we saw the mortality change from infectious disease to chronic disease. But as we're making progress on these various chronic diseases, and as we increase physical activity and movement in our elder adults, and because they're living with heart disease and cancer and CLRD and surviving stroke, and they're not dying from it, we're going to see elders moving around and falling. And when they fall, they're going to die. And so we may see, my premise might be, is that we actually may see unintentional injury moving up as a leading cause of death, and that's not necessarily a bad thing.
Well, I can't agree with that last part. But I think stepping back from the United States, as you know, with the recent Global Burden of Disease project, we're actually seeing injuries rise as a leading cause of death internationally. And so that's a real problem. I feel that part of my job at CDC is to do 2 things right. 1, get the science right, but 2, get the communications right. And that's the second piece of that is something why I spent a lot of energy thinking about how to communicate things out. I talked in my presentation about the importance of the whys. Telling our story, how we tell our story, how we graphically represent our story is critically important. I think we don't do that well enough yet, and that we can learn from others who do it better, who have historically done it better, to raise visibility in the platform for injury prevention writ large. That's what we're all about. That's what we all care about. I think we just haven't figured out what that key element is to amplify the message on the sort of biggest or grandest stage. But I think we're close. It's frankly, when I was preparing the talk and reading those stories from the last couple of weeks, I have to reluctantly admit to you, I teared up a couple of times when I was typing what I wanted to say, and with 2 of those children, with Kayla and Tyreek. That just the thought, I mean, literally, this has happened in the last several weeks. Tyreek died less than 2 weeks ago. It's just impossible for me to wrap my head around, and frankly, emblazons me to do what we do in injury prevention. Hi.
Amy Teddy from Mark Zimmerman and Dr. One of the issues that we have had is involving the safe sleep messaging, and where does that kind of fall on the agenda of CDC and falling under the injury umbrella? And can we expect, are you aware of any initiatives that are underway currently that will help us have evidence-based materials to try and change these issues that we're having?
Sure. I think, as I mentioned, infant suffocation was one of the areas that has actually risen in the last decade, and other federal partners within HHS have also been doing work in the area. The Back to Sleep campaign is one specific example. I think, I think there's a lot of energy around continuing that dialogue, moving it forward, and messaging out on what we can do to prevent co-sleeping and other things that put kids at risk for infant suffocation. So I think there's a lot of opportunities there. We are trying to, every injury, I mean, it's sort of like that, what I just said about those individual stories. Every child death, every injury death is a real problem for us. It's a problem, especially once I hear those stories. And I think infant suffocation is one that's particularly difficult to come to terms with. So I think we're doing more work in the area. There's a federal working group that's looking at the issue as well. Hi, Joan.
Hey, Joan Dewey from the Indiana State Department of Health. I served on our state child fatality review team for 4 years and was struck by the overlay between infant sleep deaths and prescription drug abuse. And CDC recently published findings about motor vehicle fatalities and prescription drug use also. And so sometimes I think that, you know, because we're very focused on an issue, we sometimes don't look at the integration, the overlay between these injury issues, and I'm just wondering how CDC can help us do that.
That's a very good question. Several weeks ago at a conference in Columbus, Kate Carr, the CEO of Save Kids, said to those of us assembled, we need to do more work in understanding and sort of messaging around child injury as a cause writ large. And I think your point's well taken. We've really struggled, I think, because each of these separate injury topics has strong advocacy organizations behind them. But taken together as a whole, I think that's where the power in numbers from that sort of shared messaging gets a little bit more complicated. Kate's a very passionate woman. Gary's a very passionate leader as well. I'm pretty confident that we can figure out how to frame and message things like child injury under a broader umbrella to get it raised as a conversation piece to the American public. I think it's something that we've all struggled with for some time. I think it's a very good point that the sort of interdigitation of injury issues that they can occur in very complicated ways is a real problem. Your point around sort of I've had recent conversations on the increase in drug driving, so the intersection between our prescription drug abuse problem and motor vehicle related fatalities. Complicated issues, wrapping our head around how to deal with it is, I think, those are still open questions for us, but it's a good question. Thanks.
We probably have time for one more.
Hi.
Hi. So just to take what you said one step farther, I think I'd challenge the CDC and everyone in this room to think not in terms of unintentional and intentional injuries, but really how do we keep our children and youth safe? I mean, a lot of the strategies around parenting are the same for all kinds of injuries. So how is the Injury Center working on kind of the intersection between intentional and unintentional?
Sure. I think I think that one voice messaging is absolutely critically important. I think it's things like child supervision, as you appropriately point out, are sort of a cross-cutting intervention that deals with many of these issues. That's why programs like nurse-family partnerships that have an opportunity to deal with violence-related issues as well as home-related problems are sort of a strong intervention with multiple opportunities. What more can we be doing? I'm not sure. I'm not sure, candidly. I mean, I think, Becky, you know real well the folks who are doing work in appropriately so in violence, in intentional injury, and violence prevention are appropriately incredibly passionate. And we all have more work to do and more need for focus on our activities. So to the extent that we can marry those conversations, I think that's fantastic. We at CDC, with the current leadership team in place, have energy, and we regularly interact around shared risk factors as a specific example. So we recently created an alcohol risk group, given that alcohol has a touch point, as you indicated, between intentional and unintentional injury prevention. So good questions. I think it sort of bridges back into my earlier remarks about the importance of communication and messaging and figuring out how to do that better. So thank you.
Thank you, Ben.